Welcome to the Brief Interventions to Prevent Suicide, an introduction webinar presented by the American Psychological Association. Thanks so much for joining us. APA is delighted to bring you this special webinar made possible through a partnership between the APA and the Prevents Reach campaign to provide evidence-based psychological and suicide prevention resources to mental health providers. The President's Roadmap to Empower Veterans and End a National Tragedy of Suicide, PREVENTS, focuses on a holistic public health approach to suicide prevention for veterans and all Americans. Let's begin with a few housekeeping notes. At this time, all lines are muted. If you require technical support, please do submit questions within the Tech Support tab that you see on the right side of your screen. That is not to be confused with the Q&A tab. You should be able to see the slides live. If you experience any technical issues, please try to first refresh your browser and then try a different browser if needed. If you are behind a corporate security wall that has not approved this website for access, please contact your technical support team. To view the slides in full screen mode, click the screen icon next to Live, which is found in the lower right side of the slide, and then press Escape to exit full screen if needed. To access the PDF file of today's slides, scroll to the bottom of your screen and click on the link under the Handouts tab. We do encourage you to submit questions about today's topic through the Q&A tab on the right side of your screen throughout the presentation. Questions will be answered during the last 15 minutes of the webinar. Due to time constraints, we may not be able to answer all questions. If you would like to rewatch this session, a recording will be available within 5 to 7 business days of the original air date. You will be able to access it from your course dashboard. To obtain the 1.0 APA continuing education credits offered for this webinar, you must click OK when you see the attendance verification box appear on your screen during this webinar. All you need to do is click OK. Remember to respond to all attendance verifications you do see. You must also complete a webinar evaluation, so stay online through the conclusion of the webinar, and then you will see a pop-up appear on your screen with access to the evaluation. A CE certificate will be emailed to you and will also be available for download in your course dashboard. Should you have any questions about continuing education credits, please just email cpe@apa.org. It is now a pleasure to introduce today's presenter. Dr. Bryan is a board-certified clinical psychologist and stress, trauma, and resilience Starr Professor of Psychiatry and Behavioral Health at The Ohio State University Wexner Medical Center. He is an internationally recognized expert in suicide who has published over 200 scientific articles and multiple books focused on the clinical care of suicidal patients, including Brief Cognitive Behavioral Therapy for Suicide Prevention. Dr. Bryan, I'll turn the program over to you. Dr. Bryan, are you there?
Here. Sorry, I forgot to unmute my mic.
Okay, no problem.
So good morning, everyone, or good afternoon, as the case may be, depending on where you're located in the world right now. What we'll do over the next hour is provide you with just some introductory information about several interventions that have garnered some empirical support for reducing the risk of suicidal thoughts and behaviors, especially amongst military and veteran populations. We will be focusing primarily on psychosocial or behavioral types of interventions in this particular presentation. That's for a number of reasons, one of which is, as a psychologist, that's the primary focus of my work, is behavioral interventions. But secondarily, there's a consensus now that psychosocial and behavioral interventions seem to have garnered a higher level of empirical support as compared to existing evidence looking at pharmacologic or other biological interventions. So to start off, to set the stage for what we'll be discussing today, I'd like to first review what we know about treatments that are most effective for preventing suicidal behaviors. And this sort of idea of what matters the most in such interventions is something that clinical researchers have been pursuing for several decades now. And it was about 10 years ago that David Rudd conducted a review of the available published trials at that time, and really sort of isolated several key ingredients or characteristics of the treatments that seem to be most effective for reducing suicidal thoughts and behaviors. And in that review, he required that a published trial have not only an active or experimental treatment or therapy, but also a control. And that way, the intent was to see if there was a difference between two comparison conditions. What was it that was different about those two treatments, that one seemingly did better than the other? And then likewise, was there some patterns that emerged over time whereby some interventions are the ones that are consistently better or performing better? Do they have some commonalities amongst them? And so he identified 6 key essential ingredients for effective interventions. The first one is that treatments that seem to be highly effective for reducing suicidal thoughts and behaviors are typically based on a simple, empirically supported conceptual model. And what this means is that there's a good theory that explains why do people die by suicide, why do they think about suicide, or why do they attempt suicide. And critical, though, is that the theory needs to have garnered scientific support because if it's an unsupported model, then in essence, we would be sort of targeting the wrong things within the context of the treatment plan. Empirically supported models also seem to be very key for the patients because it provides for them an explanation, a way of understanding why do I feel the way that I feel, why am I doing the things that I'm doing, and then why is my treatment plan or my provider encouraging me to pursue certain courses of action and asking me to do certain things within the treatment process. A second key ingredient is fidelity by the clinician. This refers to reliability of administration of the treatment process. Treatments that have been shown to be most effective tend to be based on either a manual or a protocol of some form or fashion, and there's accumulating evidence that when a clinician follows the protocol in the prescribed manner, results tend to be better. There's greater reductions in suicidal thoughts and behaviors. And the reason for that seems to be that it ensures that the key essential elements of the treatment package are delivered at the right time, in the right sequence, in the right order. The third key ingredient is adherence by the patient. So this is perhaps a not so surprising aspect of treatments that work, but patients who do not come to therapy are less likely to benefit from the therapy. Patients who don't engage or follow the recommendations, such as doing homework assignments, things like that, are less likely to experience benefit. And this is something that we've started to recognize and demonstrate within our own research, is that when patients engage in the tasks, when they do the things that have been prescribed in these therapies, they tend to experience faster reductions in suicidal thoughts and behaviors. A fourth key ingredient is an emphasis on skills training. And so the most effective treatments really, in essence, show patients what to do, allow them the opportunity to practice concepts within the therapeutic session meetings, and then also schedule time for that applied skills application outside of the therapy session. So in essence, doing the things in real life. The skills training aspect seems to be much more important than more of the verbal talking aspects of the therapy. The fifth key ingredient is prioritization on self-management. And so traditional approaches to treating and managing suicide risk have largely emphasized external sources of support, whereby patients are encouraged to contact crisis hotlines, to go to the emergency department, to call emergency services. Hospitalization is another commonly used strategy for managing suicide risk. What we're starting to learn now is that the most effective treatments certainly do place or have a role for those external interventions, but they prioritize more of the internal self-management aspects, whereby treatments empower suicidal individuals to manage distress on their own, to solve problems in their own life. And then the external sources of support tend to function as sort of a backup system or a plan B or a safety net. And indeed, that is the sixth and final essential ingredient of effective interventions for risk, is that having that ready, easy access to crisis services is absolutely key. So that the patient knows exactly what to do, when to do it, whom to reach out to when an emergency arrives. Incidentally, a new meta-analysis was just published within the past few weeks by Catherine Fox and colleagues. And what they found based on 50 years of published data was that many of these concepts that were identified by Rudd in his narrative review, now they've been able to sort of demonstrate that empirically and provide further support. So for instance, there's some findings that when a treatment focuses specifically on suicide risk rather than the psychiatric diagnosis, we tend to see greater reductions in suicidal thoughts and behaviors. So that's very consistent with element one, as well as element two, faithfully sticking to a protocol. And they've also identified that some strategies or treatment packages seem to perform better than others. And we'll talk a little bit more about what some of those treatment packages are here. So I'm not going to review, 50 years of clinical trials. We certainly don't have time for that. But one of the key findings of that recent meta-analysis was that when we look at different therapeutic approaches and modalities for suicide risk management, the largest aggregate effect sizes seem to come from treatments that are designated as cognitive behavioral in their approach, meaning that they really emphasize on specific interactions between thoughts, emotions, and behaviors. Overall, when we look at all of the CBT trials that have been published over the past several decades, the pooled effect size would suggest that there is, on average, about a 20% reduction in suicidal thoughts and behaviors as compared to whatever the comparison treatments are. But one of the more interesting findings as well is that within the past decade or decade and a half, it seems to be that the effect sizes are actually increasing for CBTs. And so a sampling of studies that have been published in more recent years is on the screen right now, and these are outpatient suicide-focused treatment trials. You can see here that Greg Brown's study of cognitive therapy for suicide prevention, David Rudd's study of brief CBT for suicide prevention, Gisèle Maillard's study of the OSIP approach, which is attempted suicide short intervention program, and then more recently a pilot study by Signor and colleagues testing brief CBT for suicide prevention in an adolescent youth sample. And what we're seeing is that in these studies, all of which are comparing the active treatment, which is based on cognitive behavioral principles, to treatment as usual, so existing forms of mental health care, we're seeing now reductions in suicide attempts on the magnitude of like 50% or larger in these particular treatment approaches. So this would suggest that we're refining and getting even better at reducing suicidal behaviors as compared to historically where we have been, even with other therapeutic approaches that fall within this family of cognitive behavioral therapy. Likewise, there are some newer studies investigating different components or procedures that have been extracted from these larger treatment protocols. I think the procedure that's received the most empirical attention is crisis response planning, also known as safety planning. So there are three studies that have been published over the past several years looking at these procedures, typically as a standalone intervention in emergency settings or acute care walk-in clinic settings. So the first was a study that I conducted, a randomized controlled trial comparing different iterations of crisis response planning and treatment as usual. And we found large reductions in suicide attempts up to 76%. And then two correlational studies, one by Ivan Miller and colleagues, a second by Barbara Stanley and colleagues, looking at different forms of safety planning, also conducted in emergency department settings. And what they found were, again, 20 to 50% reductions in suicide attempts, suicidal behaviors. And so we're even seeing that here now. We still only have one randomized controlled trial, but we have two correlational trials where the results are lining up in the same direction, where these sort of very brief, very targeted strategies seem to be quite potent for reducing suicidal thoughts and behaviors. So we're going to talk about each of these approaches, CBT for suicide prevention, as well as crisis response planning, in more detail a little bit later on in this presentation. But before we get to that point, I think it might be worthwhile to spend some time talking about why is it that these therapeutic approaches seem to be doing better than maybe some of our more classic approaches to suicide risk management. And so this kind of speaks to that first essential ingredient of treatments at work is what's the empirically supported model upon which the therapy is based. One of the theoretical concepts that I think is central to a lot of these treatment approaches is referred to as a functional model of suicide, or sometimes it's also known as the four-function model of suicide, where it is pulled out of sort of classic learning theory and the notion of reinforcers of behaviors that might sustain or maintain the behaviors over time. And of course, those reinforcers could be positive or negative in quality. And then reinforcement can come from both within the person as well as from the social environment, which gives us this 2x2 matrix here. And there's considerable evidence now from multiple research studies indicating that the negative internal reinforcement function, so to stop bad feelings, to get rid of internal emotional distress or pain, is a primary motive that drives suicidal behaviors. And this has been replicated actually in several studies and seems to be a core theoretical concept within the treatments that are most effective. Said another way, in many ways, you can kind of conceptualize suicidal behavior as a coping strategy for intense affective arousal or negative emotional states. And so from that perspective, a treatment plan that understands suicidal behavior as a coping strategy then teaches and demonstrates and reinforces alternative coping strategies, which are then served to replace suicidal behavior as a method for alleviating that internal emotional distress. Another, I think, important sort of theoretical concept that we're starting to understand a lot better now is the inherently dynamic nature of suicide risk. And if any of you joined my webinar a couple days ago on suicide risk assessment and screening, we talked about this and a lot more detail about now newer research really very much highlighting that suicide risk fluctuates and that fluctuations in suicide risk, certain patterns of fluctuations can be very meaningful and useful from a clinical treatment planning perspective. And that's certainly the case here when it comes to intervention. So here on the screen, I've highlighted sort of like two hypothetical cases based on some general patterns that we've seen in research studies to date, where individuals who have never attempted suicide, or sometimes they've attempted once, are depicted in this hypothetical red time series, where you can see some fluctuations in suicide risk up and down that aren't particularly dramatic, but they're there. And then just right of the midpoint here, we see in essence a suicidal crisis, where a person experiences a sharp increase in suicide risk that eventually comes back down to their baseline or their set point, and then they sort of proceed. Conversely, we also have a hypothetical patient who has attempted suicide multiple times in their lives. And we're seeing data now that suggests that those with multiple attempts in their history have more pronounced fluctuations in suicide risk over time. They have more frequent suicidal episodes. And then when they have a suicidal episode, they tend to last for longer periods of time. Critically, we now have some preliminary evidence that when individuals with multiple attempts kind of have these episodes, they sort of shift very suddenly to a high risk state, and then they'll shift suddenly back to a lower risk state. And so what this means from a treatment perspective is, if we understand that suicide risk is inherently dynamic, it fluctuates, it ebbs and flows, a key element of these treatments that seem to be most effective is teaching the patient how to recognize these ups and downs, and most importantly, how to know when they are entering into an increased risk state so they can recognize it and then employ very specific strategies that are designed to bring them back to a lower risk state. So this is referring to that third key element of, or central ingredient of effective treatments, of a skills training approach, combined with key ingredient number 5, which is self-management concepts. And then the final theoretical piece that I wanted to introduce here to kind of help frame our discussion is this case conceptualization model referred to as a suicidal mode. The suicidal mode, in essence, articulates that suicide risk has both stable and dynamic properties. So the stable aspect of suicide risk is those elements of suicide risk that sort of persist over time. For example, you'll have patients probably on your caseload now, or at least in your past, that you can reflect upon and say, they seem to be sort of predisposed to becoming suicidal. It was easy, seemingly, for them to become suicidal, and they tended to be chronically suicidal. That captures this notion of stability and suicide risk over time. And a lot of the research now is suggesting that there are two key aspects to stable, persistent aspects of suicide risk. The first is deficits in emotion regulation, and the second is deficits in cognitive flexibility. And so the persistence of suicide risk over time seems to be a manifestation of difficulty knowing what you feel, difficulty selecting strategies and successfully using them to change how you feel, and then difficulty in seeing sort of like the gray area between these sort of more extreme, black and white aspects of world perceptions and views. Then there's also the dynamic aspect of suicide risk. These are the fluctuations that we see on a regular basis and are related to many of the risk and protective factors that we're aware of, mood, hopelessness, perceived burdensomeness, substance abuse, agitation, sleep disruption, so on and so forth. And on the right-hand side, it's not the greatest image here. I'm not sure PowerPoint is always the best to kind of really articulate some of these ideas visually, but that gray 4-way arrow in the center is really designed to convey that all the many risk and protective factors that we've identified for suicide interact with each other. It's more of a network where thoughts and behaviors and emotions and physiological sensations sort of interplay with each other. They push and pull on one another. And what we do then from a treatment perspective is, as we understand the patient's experience and the conditions under which they arrived at a suicidal crisis or attempted suicide, we can plug in their information into this case conceptualization model. And then the treatment really is focused on dismantling the suicidal mode. And we do that specifically by teaching skills that hit on the stable aspects of suicide risk. And so the treatments that work best seem to all surround the notion of identifying emotions, and then using certain behavioral and cognitive strategies to see the world in a flexible way, to manage internal sources of distress, as well as to react in more flexible ways to changing conditions and problems as they arrive in a person's life. And so, having laid that sort of conceptual foundation, let's now spend some time talking about several of the interventions that have garnered the most empirical support and could arguably be most useful for integration into clinical practice. And I'm going to begin with brief cognitive behavioral therapy for suicide prevention, or BCBT for short, which is the treatment approach that I've personally been involved in refining and testing over the past decade or so. And given, again, the purpose of this webinar to focus on military and veteran populations, this is actually the only treatment approach thus far that has garnered empirical support for reducing suicidal behaviors in military samples. BCBT is structured into three general phases, and you can see that the first of those two phases correspond with those two key vulnerabilities from the stable aspect, the stable component of the suicidal mode. In phase one, BCBT focuses on emotion regulation skills training, so that in session one of the treatment, we conduct kind of typical intake procedures. We also do a suicide risk assessment, but do it in a somewhat different way than I think we've classically thought about suicide risk assessment. I think the traditional way of approaching this is to conduct like an interview, and we have like a form, and we kind of fill out or follow questions to assess different risk and protective factors. The narrative approach is more of a storytelling approach. We'll talk a little bit more about that in a couple slides, but I think there's a lot of benefits to it that we're starting to recognize now empirically, as well as qualitatively. The session one of BCBT then includes the formulation and creation of a crisis response plan, and then also also conducting means safety counseling. And we'll actually talk about crisis response planning and means safety counseling here as separate interventions in a little while. Then over the rest of the first phase, sessions 2 through 5, we do other aspects like treatment planning, but then you see we target, it's very behaviorally oriented. We target sleep disturbance, we do relaxation, mindfulness skills training, and then reasons for living, survival kit. Survival kit, some of you may be familiar with the HOPE kit or the HOPE box approach. It's the same idea. We just use the term survival kit because in our work with military populations, which is predominantly male, we found that survival kit was sort of a more acceptable term as compared to HOPE box. Then in the second phase of BCBT, we focus on cognitive flexibility, that second aspect of stable suicide risk. And here in sessions 6 through 10, we do some fairly bread and butter typical psychotherapeutic interventions, things like ABC worksheets, challenging questions worksheets, identifying patterns of problematic thinking, which sometimes are also referred to as like thinking errors or cognitive distortions. And then we also do some behavioral things like activity planning, coping cards. The key aspect here is that when we're doing these worksheets and these activities, we directly focus on suicide-related thoughts and behaviors. So as an example of this, we have research finding that certain thought patterns are very, very highly indicative of vulnerability to suicidal behaviors. Things like, I can't take this anymore, I deserve to be punished, nobody cares about me, no one can help me solve my problems. And so in this stage, we're targeting those belief systems and thoughts that were operating and within conscious awareness at the time of the suicidal crisis and or a suicide attempt. That way we're focusing directly on the processes that are most proximally related to the suicidal crisis, and we don't necessarily focus on other maladaptive thought processes, which certainly aren't helpful, but they're not as closely related to suicidal thoughts and behaviors. That's a critical element and distinction for maximizing the success of BCBT. And then finally, in the third and last phase of BCBT, we focus on relapse prevention, and this includes an imaginal task called the relapse prevention task, sort of cleverly named a relapse prevention task. We, in essence, have an individual imagine themselves reliving the original suicidal crisis that prompted them coming to treatment, or we'll have them relive that moment where they attempted suicide. But this time we have them imagine themselves successfully solving the problem or using one or more skills learned through therapy to avoid suicidal crisis. So it's a way for them to sort of rewrite the story of what happened to themselves and to mentally rehearse successfully managing their emotional reactions and solving problems. We then will create hypothetical future situations in the patient's life where, again, they mentally rehearse successfully resolving these crises. So in that sense, there's also a lot of overlap with like stress inoculation training concepts. Now, of course, BCBT is a cognitive behavioral therapy, and so BCBT does have a general session structure that we follow each time. And we do that not just because it's a CBT approach, and that's what we're supposed to do in CBT. I think the other major benefit for having template for session structure when working with suicidal individuals is that it seems to function in some capacity as a self-regulation strategy for the patient. And what I mean by that is, a lot of the patients that we work with, when they're acutely suicidal or they're chronically suicidal, they oftentimes feel like their life is chaotic. There are lots of problems going on. They perhaps feel like I'm out of control. I don't really have much influence over what happens to me. And then they're coming in and they're talking with us about potentially very upsetting experiences, life circumstances, thoughts and emotions. And so it can be challenging for suicidal individuals to engage in suicide focused treatment. And so the structure of the session, when we follow this template, sort of gives them a sense of predictability of I know what to expect when I come in. And so it gives them, I think, a sense of control and mastery over their internal experiences, as well as this sort of context, this external event or situation that they're engaging in. And I contrast that with more non-directive approaches, which in some cases, especially for chronically suicidal individuals, can seem very overwhelming because they don't know where to go, what to say, what to do. And so I think we can help to impose some structure and some level of control over their experience, which I think does help to calm them down. I mean, it's one of the many sources of sort of qualitative feedback we've received from many of the suicidal cases that we've treated, and how, when we ask how is this different from other therapies that you've received in the past, one of the themes that we hear pretty frequently is it's like I kind of know what to expect, and so it's not as intimidating, it's not as scary for me to come in knowing I'm going to talk about these, painful, difficult things. But there's sort of like a formula that we follow, and that kind of gives me a little bit of comfort to know that what's going to happen. So our session then begins with a review of assignments, and obviously after the first session, a bridge from the previous session. Critically, as we review the crisis response plan every single session. So one of the interesting sort of, I think, misunderstandings about crisis response planning or safety planning is that it's often approached by clinicians as an administrative sort of technique where it's a one and done. We do it, we've documented your plan, and so now we just move on with treatment. And there's this plan that's in your that in the notes that we can refer back to and say, well, we did the plan. I think the reason why we've sort of gravitated towards that approach is I think that with forms and with other policy requirements from different agencies, it kind of lends us to think in a more sort of litigious manner, and in a more administrative, like just do this thing to check the box so that we can say that you've done good care. But in reality, the way that crisis response planning is done most effectively in treatment is that it becomes a living document. That we created in the first session of BCBT, and then every single session after that, we constantly check in with the patient. Have you used it since the last session? What did you do? Was it helpful? Was it not helpful? What did you learn? And then we update the plan. So that things that aren't working so well, it doesn't make sense to keep that on the plan if it's not helping. Likewise, as a patient goes through therapy, ideally they're going to be learning new strategies that are very effective for self-regulation. And so we would add new strategies to the plan so that by the end of treatment, the crisis response plan will actually be quite robust, quite lengthy, and it becomes a really, really solid, useful tool that they sort of have mastered and become very competent at using. We then also review any homework assignments, any practice sessions that we've assigned for the patient. And then we introduce a new skill, new intervention. We'll always explain why are we doing it, how does it work. And then, as I noted at the outset, we allow time for practice. That's the skills training aspect of it. We don't just talk about it for 45 or 50 minutes and then say, go do it. We actually maximize the amount of time in session to do it right now together. So we can say, what was that like for you? How did it go? Was that helpful? Is this something that you could use? How would you use it in your life? We then, as I said, demonstrate and practice that skill. And then finally, we enter a lesson learned into the treatment log. So treatment log is a little notebook that we use. It's typically about index card size. You can order them, online or from any sort of office supply store. And what we will do at the end of every session, then we have them record this lesson learned, which is typically sort of like, what's the thing from this session that was most useful to you that you want to make sure you remember going forward? And so we have these like little nuggets of, insight of, I'm being too hard on myself. If I take some time to practice a breathing exercise, I can calm myself down, things like that. And so they end up over the course of therapy in this treatment log. It's in many ways creating a relapse prevention plan as you go, but it becomes now a written documentation of all the things that work for them. So it serves as sort of empowerment function. Then finally, we define treatment completion in BCBT not based on how many sessions that you attend as a patient, but do you demonstrate behavioral mastery of the concepts and skills? And so at the end of 12 sessions, if a patient is still struggling in that relapse prevention task to effectively sort of imagine themselves solving problems, managing distress, then what we do is we add on additional sessions and we keep practicing and we keep rehearsing. We keep using these skills in everyday life until that patient demonstrates the ability to effectively self-regulate. Or as I say to many of the patients that I treat, this is kind of like the final exam. Good news is you're going to pass. You will get an A on the final exam. Bad news is you might have to take the exam a few times, but you're going to walk out of here a master of how to do this. You're going to be very good at it. And that's my job as your clinician, is to make sure you're really prepared to confront these challenges in your life, to improve the quality of your life. And we'll keep working on it until we get to that point. So now let's pivot. Let's spend some time talking about the crisis response plan. The crisis response plan is, as I mentioned, it's a procedure from BCBT that we have since sort of extracted as a standalone intervention, and we have tested it as an acute care management crisis intervention. So I alluded to before as well, kind of a difference in how we approach suicide risk assessment, not only in BCBT, but it's also true in crisis response planning, where we adopt this more narrative or this storytelling approach. So I have here on the screen just some like example questions or ways that we would sort of introduce the narrative assessment, where we say, something like, let's talk about your suicide attempt. Let's talk about what's been going on lately. Can you tell me the story about what happened? Other ways that I've asked this is to say, can you tell me about the day that you tried to kill yourself? Or in an emergency department setting, if I'm seeing them as they walk in, maybe they've already made a suicide attempt. I can sit down and say, can you tell me the story about what happened today that led up to you coming into the emergency department? And so it's a narrative. It's an open-ended way wherein we invite the patient to explain from their perspective what has happened and led up to this crisis or this very, very sort of dark moment that many of them have been in. And as they convey their story, then we encourage them to give us more information by prompting them with questions, things like, what happened next? And then what happened? What were you saying to yourself? Like, what was going through your mind at that point in the story? Did you notice any sensations like in your body as that was happening? And so, in many ways, as the patient is telling their story, we are now listening for information that we can plug into the suicidal mode, that case conceptualization model that I showed you several slides ago, which then we start to formulate now as we're conceptualizing the case. What do we need to do from a treatment plan perspective? So that once we get done with the assessment, a key thing that we're finding now in some of our research is that this narrative approach significantly increases patient ratings of a therapeutic alliance, of perceived empathy, all of these sort of process factors that are absolutely key for connecting with patients in distress. And we even now have some data suggesting that therapeutic alliance, stronger rapport, stronger therapeutic alliance magnifies the suicide prevention benefits of crisis response planning, wherein, if you do a crisis response plan but don't have a particularly strong therapeutic alliance, it's better than treatment as usual. However, you get even better results if you have a crisis response plan and a strong therapeutic alliance. Interestingly enough, we also were able to find that in treatment as usual, using more classic approaches that emphasize hospitalization, external sources of support, what we found was that even with a strong therapeutic alliance, treatment as usual is not, you don't get better results in treatment as usual. And so it seems to be that therapeutic alliance alone is not necessarily very helpful for reducing suicide risk, but it's the combination of strong alliance with sort of the right procedures that where we can magnify and synthesize and get better results than we could with just the procedure or the alliance by itself. So we've started to now pivot towards this more storytelling approach. And as clinicians adopt this, what we're hearing from them post-training is that they're telling us, I feel like I'm able to listen to my patient better. I feel like my patient gives me better information. I'm better able to understand their suicide risk. So I'm better able to formulate their overall risk level. And then critically, it's a lot easier for me to come up with a treatment plan, and crisis response planning or safety planning is now way easier for me to do because I have a better understanding of what's going on and what we need to do together to most effectively help that patient. The crisis response plan is divided into these several sections. You'll see probably many of you are familiar with this, especially if you have any familiarity with safety planning. The only primary differences from safety planning is we have an explicit section that includes reasons for living. And we found in our research that actually leads to faster reductions in suicidal thoughts and behaviors, to spend some time talking about why do you want to live or what gets in the way of suicide, and then including that on the crisis response plan. We also show that it increases optimism, a sense of purpose and meaning in life, so there's a lot of benefits. The other difference is on the crisis response plan itself, we do not have a section that focuses on means restriction. We're going to talk about that here shortly as a separate procedure. We've basically conceptualized crisis response planning and means safety counseling as two separate procedures that we often do back to back with each other, but we found in a lot of our work with patients that sometimes it can help to separate those two concepts, because oftentimes the means safety counseling piece is the harder conversation to have, especially if the means safety counseling involves a discussion about firearms. And so we've kind of created this a little bit of a wall between the two, where the narrative assessment sets us up nicely to build a rapport to easily do the crisis response plan. We can conclude that. Now we usually have very high levels of buy-in and confidence from the patient and trust, which then allows us to more easily and effectively switch to a conversation about access to lethal means. Here are two example crisis response plans. These are from two actual patients that I've treated over the past few years. We just rewrote them, obviously, to protect their privacy. But you can see how we just handwrite them on index cards. And so it's kind of a low cost, easy way to do it. We've moved away from forms in our practice. That way there's never like a blank section if a person can't think of enough items. Things like that. But we also found that sometimes using the index cards seems to reduce the likelihood of someone losing their plan, because it doesn't get sort of mixed up in the shuffle of paperwork received when they're discharged from the ED or from an inpatient unit, something like that. They can keep it in their pocket or their purse or their bag, something like that. And then you can see on the right-hand side as well, this was a case where I over the course of therapy, this was actually his crisis response plan at the end of therapy, and you can see how we updated it and modified it where things are, scratched out. We have listening to music, but then he qualified it with uplifting music to be more specific. And that's why some of the numbers, there are multiple 5s and 6s and 7s and 8s, because over the course of therapy, he learned new strategies and he added it to his crisis response plan. So that brings us then to the final topic, which is means restriction or means safety counseling in general, but I'm going to focus specifically here today on firearms as the method, because this is where most of our research has been conducted over the past few years. Um, what we have found to be most useful is to adopt a motivational interviewing based approach to firearm safety counseling and means restriction counseling in general, and this is true of all, I guess, regardless of the method that a person is contemplating for suicide. And in motivational interviewing, we sort of think of 4 phases to the counseling process, where we begin by establishing a collaborative working relationship. We then move to focusing, where we adopt this guiding approach, where we're not being too directive, but we're also not just being non-directive and following. We then transition to an evoking stage, where we kind of elicit their thoughts and opinions about the topic, their ideas about change or not change. And then finally, we move into a concrete planning stage. So as I mentioned before, we've traditionally done crisis response planning and means safety counseling as separate, or we conceptualize them as separate ideas. And so the crisis response planning phase oftentimes serves the purpose of engaging the patient, and then can also help us to move into focusing, where it's about sort of helping them to achieve their goals, so that then as we pivot towards a more explicit conversation about means restriction, we sort of, I think, covered a lot of ground in those first 2 counseling phases, and it helps us to move more directly and rapidly into the evoking stage, where we can really focus on understanding their thoughts, their perspectives, and their opinions about restricting or limiting their access to various methods. I have here sort of an example of sort of like a sample script, so to speak, or transcript of how we have done this with firearm owners. And I'm happy to sort of announce that we actually have a study about to be published in collaboration with Mike Anestis at Rutgers University, who is the principal investigator, where we conducted a randomized controlled trial of lethal means counseling with firearm owners, military personnel who are firearm owners. What we found was that lethal means counseling using this approach significantly increased rates of safe storage of firearms, so using locking devices, gun safes, things like that. And so that's forthcoming. Hopefully, will be out in the next few months. We're really excited about it. We now do have empirical data supporting this approach when used with military, not only just military personnel, but also military personnel who own firearms, which is oftentimes a more sensitive or delicate conversation to have. You'll see here an example of engaging. We found one of the greatest ways to engage, like a gun owner, for instance, is to just ask them, like, what kinds of guns do you have? And just invite them to share their interest in the topic. We can then focus them on the topic of safety by asking, what are the safety procedures that you currently use? Then transition into evoking, where it's a lot of open-ended questions, just kind of asking them, what are the conditions under which you might increase or change your safety practices? What are your thoughts about, someone who's upset having access to a loaded weapon? What about someone who's suicidal? Do you think a suicidal person should have access to loaded weapons? We found that by and large, of course, suicidal individuals or gun owners say, well, no, that's probably not a good idea. And so that oftentimes helps us to then say, well, it sounds like then you have this sort of value about safety and protecting people, especially when they're in vulnerable states. I'm wondering then how it applies to you, because you're in this vulnerable state now, and you have easy access to weapons. How would your sort of belief system and your value system apply to your conditions right now? And we found it was a really nice way to help them to kind of shift their thinking about means restriction. When even, if initially they were maybe resistant or opposed to the idea. And then finally, we move to that planning stage, and we will actually develop a written plan with them, a written means safety plan on a separate form. And wherever possible, we like to include other people, like family members, friends, so that we can elicit aid and support, but also it helps out with a level of accountability. So it's fairly routine. And once we're in the planning stage, to ask individuals, is there someone in your life that we could ask for help to make sure that this plan is put into place? So the last thing I'll note here is just that you'll see, my hope is throughout each of these interventions, a big premium is placed on respecting the patient, the suicidal individual's autonomy to really put them in the driver's seat. So we're guiding them to hopefully make decisions and pursue options that will help them to improve the quality of their life, to reduce their risk for suicide, and doing that where they kind of feel like they're in charge of what's happening, as opposed to us imposing and saying, this is how things are going to happen, this is what we're going to talk about, this is what we're going to do. Okay, so we're at about time to take some questions. I'll start sifting through some of the questions that have been submitted here. But if you have additional questions, go ahead and send them in. It looks like there's a lot. I don't know that we'll be able to get through all of them, but I do have my email address on the screen, so that if you have questions that I'm not able to answer, or you have a new question afterwards, feel free to shoot me an email and I'll respond and answer the question to the best of my ability. Right. So the first question or comment is, it seems like the extensive research on psychoanalytic interventions is being ignored. Yeah, what I'll say is that the research base isn't as extensive, at least for suicide risk reduction. There is one approach from the psychoanalytic tradition called minimalization-based psychotherapy that has actually been shown to reduce suicidal thoughts and behaviors as well. There's one randomized clinical trial testing that particular approach. So we're still waiting for some additional trials to further replicate and confirm its initial findings. That meta-analysis that I just mentioned by Fox and colleagues, though, did actually include several psychoanalytic studies, and overall they're finding that the effect sizes are not as pronounced. And so it wasn't so much that I was deliberately trying to ignore any particular school of thought, but much more intending to focus on the interventions that we have the greatest amount of empirical support for, especially within military populations right now. As I mentioned before, the only treatment approach or modality that has demonstrated efficacy for military personnel is brief cognitive behavioral therapy. So the second question, can you speak to the effectiveness of formal peer support in helping to prevent suicide? Good question. So well, here's another situation where we don't have a whole lot of empirical support just yet. But incidentally, we're conducting a trial right now at a military installation to test a peer-based intervention. What's different about that, of course, is it's not hinged upon mental health treatments per se, where what we're doing is, in that approach, we're looking at how can we leverage peers to change sort of the environment, the workspace, the community. So it's more of an occupational health approach, wherein we say, basically, we're conceptualizing suicide risk not as a thing within individuals that has to be identified, screened, rooted out, and changed, but instead we're conceptualizing suicide risk as the outcome of environmental strain and pressure. And so how can we leverage peers to influence change within the system itself, so that the environment is imposing less stress on individuals? Very similar to the model that I found most helpful to think about this is sort of like how we do asbestos mitigation. One approach is to work and live in buildings with asbestos, and we just issue PPE to everybody so that so we reduce their risk. The other approach is to remove asbestos and to not even build buildings with asbestos in the first place. And so that's kind of how we're approaching the peer model right now is, can we do something to the environment where we remove hazards entirely or mitigate exposure to those hazards, as opposed to always relying solely on mental health treatment solutions, which I would say is akin to like personal protective equipment, where you're not actually changing anything, any of the hazards that are driving someone to be suicidal. You're just hoping that the PPE will be strong enough to withstand the hazards that continue to be present. So it is a different approach. My hope is we'll see what happens. The feedback so far has been very positive on that peer program. We'll see how it ultimately pans out, especially since, one of the challenges right now is, as soon as we started the project, COVID hit. And so it has really kind of altered all of our thinking about how to approach community-based intervention. So we'll see what happens. Is there evidence that the therapeutic relationship by itself is an integral part of suicide prevention? I'm referring to the feeling that the patient feels understood and connected to the psychologist. So perhaps you submitted this before. I talked about that a little bit, but just as a reminder, at least what we're finding now, there's about 3 or 4 studies that have looked at this, showing that the therapeutic alliance by itself does not seem to be correlated with reductions in suicide risk. But it seems to magnify the effects of empirically supported treatments. And so where this has been studied is not only in brief CBT and crisis response planning, but also in dialectical behavior therapy, where it seems to be it's sort of the combination of good alliance and good intervention that matters, which kind of makes sense if you really think about it. It's sort of like I'm reminded of a quote that Marshall Linehan, I heard her say many years ago. It's like, like being warm and empathic isn't enough. You also have to have a good intervention, and that seems to be what the data are bearing out right now. So a question, typically therapy treatment trials exclude people with severe intense suicidal thoughts and recent attempts. Do these studies include all participants regardless of level of SI? Yes. So actually, if we back up to these trials, so you'll see there's under the column sample, I say here, so in Brown's study, the requirement was to have attempted suicide within the past, I think it was like 2 to 4 weeks. In the Rudd study, it was you needed to be actively suicidal in the past week or have attempted suicide in the previous month. Guissen-Maillars was attempter, so attempt in the past month. Signor et al., I think, was also current ideation or recent attempts, but these were also adolescents who were recruited off of an inpatient unit where they were hospitalized for suicide risk. And so this was the post-discharge treatment plan. And then, all of these studies looking at crisis response plan and safety planning. I don't list it here, but the inclusion criteria in all of these were actively suicide. So basically they were walking into an ED or an outpatient acute care setting and saying, I am in distress. I am thinking of killing myself right now and I need help. So these are deliberately selected high risk samples. The next question, are suicidal attempts behaviors including NSSI, or is this only relating to ideation attempts that, these results that I'm reporting are specific to suicide attempts. So those slides that I just showed, again, the primary outcomes were trying to kill yourself, or in the Stanley study and the Miller study, they included attempts as well as like preparatory behaviors. So starting to make an attempt, but then stopping yourself. And in each of those studies, ideation also was considered as an outcome. What we see is that on the ideation side, we tend to see faster reductions in suicidal ideation in these therapies, usually by the 3 to 6 month mark. And then after that, after those first few months, treatment as usual usually catches up. So eventually other therapies do catch up, at least on the ideation side. The other therapies never really seem to catch up in terms of behaviors. NSSI has not been looked at as an outcome as much. There are some data suggesting that perhaps these, at least DBT, for instance, there's some mixed results. Some studies saying that DBT does reduce self-injury. Other studies suggesting that maybe it doesn't, that maybe the effects are specific to suicidal behaviors. Next question, to what extent have RCT participants been comparable to suicidal patients in the general population? They're actually pretty generalizable if you were to go and look at the studies. So the Brown study, I think, one of the other nice things about the studies I presented is they reflect a pretty diverse group of individuals. So the Brown study was conducted with primarily low income, racial ethnic minority, individuals living in like inner city. And so they had high rates of homelessness, substance abuse, those sorts of problems in life as well. The Rudd study was done with predominantly men, although it was a racially diverse sample that was with active duty military personnel. And then the study with youths, I think it was a slightly larger female population. But you can see in those, when you look at sort of their clinical profile, they're fairly, I would say, comparable to what most of us see in general practice. And the other, I think, key aspect of the studies is they minimize the exclusion criteria. So pretty much the only reason why someone would not be eligible to get into the study is that they have impaired mental status, like they're intoxicated, they're psychotic, things like that. So they cannot provide informed consent. But there are no exclusions based on diagnosis, gender, age, those sorts of things. The last thing I'll note there, and this will be the final point that I make since we're running out of time, is that at least in the BCBT study, we lent our data to the Army STARS team, who then conducted an analysis showing that the sample that we enrolled was very, very well matched to overall soldiers who are vulnerable, high risk for suicide. And so they were actually able to do a lot of really great analyses to show, like, if the results of this one trial were then sort of amplified, rolled out across the entire military, what would be the results? And one of the key conclusions that they found was that we could potentially avert 1 to 3 deaths by suicide for every 100 soldiers who received BCBT instead of treatment as usual. So there's definitely some generalizability there. Well, we're at time. I appreciate everyone's questions. Again, if you have more questions, feel free to email me and I'll answer them as soon as I can. It's been great to spend some time with you today. Hope that this was helpful, and hope that you have a good weekend as well as a good holiday season starting up soon. Thanks.
Thank you, Dr. Bryan. That is all the time we have for today's webinar, everybody. So on behalf of the APA, we would like to thank our presenter for today's presentation, and of course, we would like to thank you for tuning into today's program. Do remember, to receive continuing education credit, please complete the evaluation. You will receive your documentation of C credits soon after. This does conclude today's presentation. Enjoy the rest of your day.